get my recording. Okay, yesterday I kind of braked off this slide and I went to the chart of the dog breed issues with anesthesia. Um, Let me go back to this for a second. This is kind of just a summary of that. One thing we see in the boxers and the giant breeds, they do have a sensitivity to acepromazine. Now, giant breeds can be sensitive to a lot of different drugs. The bigger the breed, it's not that you cannot use acepromazine. You can give ACE to a boxer, you can give ACE to a mastiff. We adjust the dose. Now, there could be a better sedative to give, but say acepromazine is the only sedative you have in your practice, then you kind of have to use what you have, but you can use it and adjust it. And again, anytime I have a dog, if I have a boxer or a mastiff and I give ACE, I'm probably going to watch them a little bit closer. I mean, I watch every patient, but I know that they may have a more profound effect. That is what I'm really trying to get at. And then you have on the, the little terriers on the flip side, it wasn't really mentioned in that little extra PDF. Not that they're completely resistant, but they have a little bit of more, yes, Michaela, I did hit record. Let me check. Yep, it is recording. Thank you. Terriers can, need sometimes higher doses because, they're kind of wiry and feisty. So, and then obviously our brachiocephalics, on this slide, it only says difficult to intubate, but they have the small tracheas. They have usually the long palate, potentially stenotic nares, and they have issues with breathing. So I know, I never anesthetize a bulldog without knowing I have oxygen and where it is. Because you need to have oxygen and intubation materials. Sometimes you just sedate a bulldog. You don't necessarily anesthetize it and put an endotracheal tube. But if I sedate a bulldog, I always know where my tubes are. I have oxygen available. Usually I have it turned on and I'm ready to go if it goes sideways on me and I need to give oxygen. The sighthounds, sensitive to sedatives, but mostly the barbiturates are typically contraindicated in sighthounds. They really want you to use something else. So sometimes people think, oh, they're just sensitive to any drug. Really, it's mostly the barbiturates. Now, rare breeds, we're not sure. And then draft horses. When you get into the equine breeds, and I don't know, are you guys in large animal 1 or large animal 2? I don't know where you are with your large animal classes. So you're in large animal 1, so you're probably starting to get into breeds of horses. Now horses, all horses are sensitive to opioids. In a whole, when you use morphine, fentanyl, oxyhydro in horses, it can cause excitement. Now, if we look within horses, it's similar to dogs in a way, because like a mastiff in the dog world is like a draft horse in the horse world. They're those extra large, the Clydesdale horses. If you don't know much about horses, I'm talking about the Clydesdales or the big drafts. Now they tend to be very sensitive, just like an extra large breed dog would be. Now you have an Arabian or a thoroughbred. Those tend to be flighty breeds of horses. Two breeds that I don't really care to work with. They're just very high strung, a lot of energy. They're probably going to need higher doses. So within the horse world, there are some breeds of horses that we have to adjust our dosages. You have a draft horse, they're kind of boom, boom, boom. And you got an Arabian and a thoroughbred, and they're always like on guard. So, we're going to play with doses within horses, kind of like we do in dogs. Cats are pretty much across the board. Cattle, so some of those species, but in horses and dogs, the breeds will react a little differently. And when I get into horses, we will talk about that. I did not say, or yesterday I said, that age is not a disease, but it does influence our choices of drugs. So underneath here, and I think you said you can see the notes, when we talk about neonate versus pediatric, neonatals are like less than 2 weeks old. It'd be rare very, very, very rare we would be doing something to a neonate, some type of an operation. But if they had a massive umbilical hernia, or if the mother potentially damaged the puppy, or, maybe, you know, stepped on, it's that would be rare. But you're going to deal with pediatric patients. Some clinics will do early spaying and neutering, and they're like maybe around 2 months old, but 2 to 8 weeks old is considered pediatric. And I personally, 8 weeks, we're talking about 2 months old. I would still consider a 3, 4 month old, anything really, 2, 3, 4 months old is still considered pediatric. 6 months, we're getting close to adulthood. But what you need to think of is there's some notes here, and there's not a lot on the slide, but we have issues with metabolism. Any drug that you give an animal, anesthetic, has to be metabolized and excreted. They have an immature liver, they have immature kidneys. So we're probably going to use a lower dose, or we're probably going to use drugs that don't require heavy metabolism or have heavy side effects. Midazolam is a very good drug for pediatrics and neonates. Propofol requires very little liver or kidney metabolism, so that might be a good choice. The other thing that they have issues with is they tend to get very cold. The colder they are, it affects cerebral blood flow. It affects their ability to metabolize agents. Probably the coldest I got into a situation, I had a Yorkie puppy that had a liver shunt at Purdue, and it's a very long surgery, and you have to take the dog, you go into surgery, you place a catheter near the hepatic, the portal vein, and then we sew them up a little bit, we take them down to radiology, and then we inject a dye into their liver. So I've got a dog that's been on a heating pad, we have to transport it anesthetized to radiology, put it on a cold table, find the shunt or the abnormal flow. Then we take it back into the OR and we open it up and we repair the shunt. It's a very lengthy procedure. Midazolam, Katie, midazolam, Midazolam. It's a Valium type medication that we'll talk about. So this little puppy had been under for quite a while. It got down to 88 degrees during anesthesia, and it was dropping, and we were trying to put, heating pad, bear hugger. It's hard because that blows hot air, and you can't really sometimes use that in surgery. And then, but the moral of the story was getting cold, and the dog's heart rate was dropping. And this puppy had a heart rate of 60. Well, in a Yorkie puppy under anesthesia, I did not like the heart rate. It was starting to affect blood pressure. I gave it atropine, which normally increases the heart rate, no effect. I gave it a second dose, no effect. Gave it a third dose, no effect. Because if you think about how people survive, if they fall into, like kids that fall into an icy pond, and sometimes they rescue them and are they alive? And if they come out and they warm them up and they come back to life, but in hypothermia, the body goes into a survival mode. And that's why the dog wasn't responsive to atropine. It's kind of like the brain had taken over and gone into survival mode. Once we started to get the dog warmed up, heart rate came back up, blood pressure came up. But hypothermia is a very true thing we battle during surgery. And it affects metabolism, blood flow. So you need to keep them warm. If you're working with these patients, you got to keep them warm right off the bat. Even a little trick. Sometimes if I've got little guys going into surgery, I take a few towels, I throw them in the dryer at the clinic on hot, and I pull them out of the dryer and put them on. Now they will cool off, but that's just another trick. When we come down here, when we're talking about the geriatric patients, is their ability to potentially have abnormal hepatic or renal blood flow, older liver and kidneys. They are also sometimes have a lower body mass. You know, as a dog gets older, they lose some of their muscle development. And sometimes it affects them when they're recovering from anesthesia because their ability to shiver, their ability to stay warm. So hypothermia for both of these neonates and geriatrics are still an issue. I mean, it's an issue for any patient, but these patients it can be a little worse for them than like a normal 1-year-old dog. And there's some notes under here. Again, neonatals and geriatrics, we don't have great organ development yet. They're developing. And then geriatrics can be compromised. But that's why we do that protocol, why we do the geriatric protocol, check liver, kidney, make sure that's all working out properly. I went into this a little bit yesterday, but we need to know now obviously if they're for a spay or neuter, then we probably know their sex and we probably know their status. But heat and pregnancy are two factors in an intact female. Obviously, if they're pregnant, normally you're not doing surgery on a pregnant dog because any drug you give the mother is going to go to the fetus. Besides doing a C-section, it'd be rare for a dog to have a dental or have some orthopedic surgery while it's pregnant. Usually we would try to wait. But when they're in heat, they have a higher blood volume. Everything's a little more engorged. Their tissues are inflamed. They can be a little more sensitive to drugs. They can bleed a little more. We may need more fluids. And some things that we factor in here. If you are working on a stallion, and for those of you who don't know, a stallion is an intact male horse. A horse that has been neutered, that's a male, is called a gelding. Okay, so if you hear stallion, they have their testicles. And usually the only reason you have a stallion is typically for breeding. I mean, again, because they can be flighty, they can have a lot of testosterone. So a lot of people that if you're going to have just a pleasure horse that you go riding in the trails, you're probably not going to use a stallion. You're probably going to want to get them neutered. The issue with acepromazine, and I will get into this deeper, but ACE causes prolapse of nictitating membranes. A nictitating membrane is a membrane that comes out and retracts. The third eyelid, if you see when your dog sleeps, and sometimes you wake them up and there's a little bit of a lid, or like a little pink over the eye, it's an eyelid that is retractable and it protects the eye. When we give them acepromazine, a lot of times that little lid comes up because it's a prolapsed membrane. It's nictitating, meaning it can move back and forth. The penis is the same thing. Now, in a dog or a cat, it's not necessarily an issue, but a stallion, I mean, horses have a large amount of erectile tissue. If that penis extrudes during sedation, it won't always go back. And the problem is the longer the penis stays out, it can dry out, it can become damaged. And if it's a stallion being used for breeding, then that can be a problem because, a lot of times stallions for breeding purposes can be a financial, it's a financial benefit to the owner. So we want to be cautious in that. And then xylazine is a drug that's a little more, if they're pregnant, they can have a little more sensitivity to it. So those are reasons why we need to know this. Now, I'm not going to get into the specific medications that you need to know because of interactions. That's going to be more for the doctor to know. There is a note here. The one I will recommend or that I will talk about is antihistamines. A lot of dogs, their owners put them on Benadryl because of allergies. One of the side effects of Benadryl is drowsiness. So if I have a dog that comes in for a surgery and I'm going to give them a sedative and they're already on Benadryl, it can potentiate my sedative. I may have to give a lower dose. And again, when a dog walks in the clinic, they might be crazy. They don't necessarily look very sedate, but if they just had Benadryl that morning and then I give them like ACE and butorphanol, they can co-enhance each other. So an antihistamine, you know, a lot of these other drugs are very specific. I mean, obviously they're on antibiotics. We need to know that. Aspirin, I would add to this. We need to know that. Now, aspirin doesn't necessarily affect my anesthetics, but it can affect clotting for surgery. These are ones that have more of an interaction with the anesthetic agents. And like I said, this is the one you're probably going to see the most because a lot of people give their dogs Benadryl over the counter, and you need to make sure you know that. One thing that is helpful is any allergies or drug reactions, but you want to ask them, has this dog had surgery before? Has this dog had anesthesia? Most people will give you that information. But things we like to know, ketamine is used in a lot of cat protocols. Ketamine is used for Kitty Magic, Cat Val. And so if there is a report, well, yeah, my cat slept for like 3 days after surgery, maybe we're going to decrease the doses. Or if a dog got acepromazine and acted out, dogs sometimes that receive acepromazine, now acepromazine is supposed to be, it's listed as a tranquilizer. It's used for sedation for like car rides, 4th of July, rainstorms. So sometimes we give acepromazine, to the owners in tablet form at home. If behavior changes are noted, some dogs, it changes their behavior. I think of it this way. It's kind of an analogy. People that drink too much and get drunk. You have good drunks and you have bad drunks. There's people that when they drink, they're not a very good person to be around. They are in altered state of consciousness due to consuming too much alcohol. And they're either going to get really happy and lovey, or they're kind of going to be a person you don't want to be around. Sometimes when we give acepromazine to dogs, what we do is we take away some inhibition because they're sedated or tranquilized. They're in an altered chemical state. That dog sometimes can act more aggressive because what you've done is you've given him a drug that's taken away inhibition. And then they act like they're not supposed to. You're like, my dog knows he shouldn't do this. Well, your dog right now is on a chemical that's altering his consciousness. So that's my point, is if someone says, yeah, my dog got this sedative and then he tried to bite my kid, let's not use that sedative. So you need to pull out of the owner, has your dog ever had sedation? Has your dog ever had anesthesia? Has your animal had any problems with that? Because that has to go in the chart. Now, obviously, the big thing here is you want them to hopefully have all their vaccines. Now, some of you are working in a practice and the dog comes in and you've seen that dog every year for its whole life. I come from specialty and we met dogs for the first time. I don't know anything about their preventative history. Usually when they're sent to oncology, I don't get a lifelong's worth of chart. Okay, we usually get what's pertinent to the case. So I can always call the clinic and find out, but do they have their vaccines? Are we up to date on parasites? But I would think the most important thing, there's some notes here underneath, but the most important is the heartworm status. Has this dog had a heartworm test recently? Is this dog on preventative? Again, a dog that is heartworm positive, and there are stages of heartworm positive. The later stages, that heart is filled with worms. The vessels going to the lungs are filled with worms. It impairs circulation. And when you anesthetize that dog, you anesthetize the worms and they can become floating clots. So again, we're not going to just operate on a dog heartworm positive willy-nilly. You can do it, but you really want to know that they're negative, That's going to be the best for the patient. When you start talking about pre-existing diseases, I a lot of times say, is your dog, how does your dog eat? Does your dog eat a full meal? Has your dog had any vomiting or diarrhea? Any coughing? Polyuria and polydipsia. Hopefully you know by now what that means. Drinking a lot, urinating, PUPD. For those of you that don't know tenesmus is difficulty defecating or straining to defecate. Dysuria is difficulty urinating. Now, I'm going to tell you, between the two, there's a lot of people that just let their dog out in the backyard. They don't necessarily watch it, or they see it straining. And I'm going to tell you, this is important. If someone comes in and says, my dog is straining to defecate, they will also strain when they have severe colitis. So dogs that have severe diarrhea, they will sit there and strain because they feel like they have to go. A dog with a UTI might be going out there going drip, 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 and they're straining to urinate. And it doesn't mean that they can't urinate. It makes them feel like they want to go. So there's a big difference between constipation. When someone says they're straining, I'm like, did you see any bowel movement? And sometimes it's like, well, yeah, it's just drip, drip. Like, that's probably straining because of diarrhea, not straining because they can't defecate. And think about it this way. If a dog was constipated to the level where they literally could not poop, where is it going to go? If they literally cannot poop because they are completely constipated or blocked, amen, Haley, they're going to vomit. If they're straining to defecate, but they're eating and not vomiting, it may not be a severe constipation, or it can be a colitis. If they're straining to defecate and they're vomiting and not eating, you need to get that dog in and you need to get them cleaned out. So there is a difference. I just bring that up because straining to defecate most of the time is diarrhea and is not true constipation. And again, a lot of these signs here, yeah, and you guys vomiting right off the bat. If it can't come out that way, it's coming out this way. It's just physics. Is there any general illness? Do they look dull? Are they slow? Some things we will stabilize prior to anesthesia. A little tip, a lot of foreign bodies come into the ER. Dog ate a towel, dog ate a toy. They've been vomiting for 2 or 3 days. They are severely dehydrated. A lot of times in the ER, we will put them on fluids for 12 hours. We will put them on fluids overnight, and we will repeat x-rays. In some cases, a little bit of hydration, the foreign body will start to move and they poop it out. Sometimes it's stuck because they're so dehydrated from vomiting that the intestines are dehydrated and they don't have enough lubrication. 12 hours of fluids, we take x-rays and we see it's moved. Dog doesn't need to go to surgery. But I will say, in dogs that have HGE, hemorrhagic gastroenteritis, severe vomiting and diarrhea, those dogs are not good anesthesia candidates. They need a little fluids. They need potentially some oxygen therapy. So if there's anything you can stabilize before anesthesia, yeah, and not sure. I'll just keep going. You can always replay this. Sorry if I'm breaking up. Potentially a blood transfusion. We've done that sometimes before surgery. The other thing is any change in behavior can be a sign of a central nervous system. Change in aggression, attentiveness. Dogs get cognitive disease as they get older. It can be that they're painful somewhere. So a dog that has been very sweet that suddenly starts to become touchy with family members or shows a little bit of growling, a lot of times there's underlying pain somewhere and they're being guarded. Sometimes it is mental, sometimes kind of it can be a change. in their behavior. But it can be a sign of, um, systemic illness if they're changing their behavior, changing their patterns. One thing that I also like to get into with owners is, what is normal behavior for them? Is this a dog that is always upstairs sleeping with you that's now hiding? That's a big red flag. A dog that always sleeps in one location and starts sleeping in other locations can be pain, systemic illness. Interaction with the family, not wanting to play with certain toys. These are sometimes are the little things that point to, oral issues. They don't chew on their toy like they normally do. They eat their food in a certain way, and I'll say, does he always eat his food that way? They're like, no, just in the last 2 weeks. We had a dog that had an oral mass way in the back of his jaw. The owner couldn't see it. It's just she noticed a little bit of drooling, and he was chewing his food differently. And then I started to get into, does he chew it like this normally? Does he eat this kind of food? And then we discovered the oral mass in the back. Okay, one thing that is key, and there's things that I like to stress, is exercise intolerance. Now, what is their tolerance for exercise? If you're intolerant, means you don't want to do it. And 3 main things. I don't want to hear that this is kidney disease. I don't want to hear this is liver disease. I don't want to hear that this dog is old. There are 3 primary reasons a dog does not want to exercise like normal: heart disease, anemia, can be musculoskeletal pain. I would even say respiratory disease. I would add to this. I don't accept any other answers for this. Sometimes people are like, they're just old. They have liver disease. They're not feeling good. You guys are in the level of the program. I don't want BS answers anymore. You have to think clinically, critically to be an anesthetist. You have to plug in your brain. I'm not accepting answers that are vague anymore. I made a comment last term on tests. And if you have to explain on a test, like, I don't know what I'm talking about, like you're going to explain it to your mom or a boyfriend or a significant other, you need to describe what I'm asking you in those terms. So if an animal's heart is not functioning properly, this is maybe a dog that doesn't, their owner runs 2 miles every day. The dog wants to go a half mile. They can't even make it up the stairs. Now, I will tell you, reluctance to use stairs is a big key in musculoskeletal pain. If their hip dysplasia starts to get worse, then I see they don't want to go on the couch. They don't want to climb up the stairs. They don't want to go down the stairs on the deck. Okay? But anytime an animal is reluctant to have activity, heart disease is on my brain, also anemia. Now, some animals are anemic and can still look fairly pink, but obviously you're going to check the gum color. But if you do not have enough red blood cells, you cannot carry enough oxygen. And if you don't have enough oxygen, you're going to have exercise intolerance. In people, one of the number 1 signs of anemia is you just feel tired all the time. You don't have energy to do anything, okay? So exercise intolerance, but again, if you have a dog that's a couch potato and then you have a dog that is a marathon runner with the owner, they're going to show different things. So I have to get a baseline from the owner. What does your dog do on a daily basis that's making you think he's exercise intolerant? Another thing I will add about heart disease and anemia, in severe cases, this will interfere with sleeping potentially or eating. If a dog is having enough of a heart issue that it's interfering with basic functions of life, eating, sleeping, resting comfortably. My friend's dog was in end-stage heart failure. And she was like, when am I going to know when it's time or it's bad? And it's like, I told her, I said, this dog should be able to eat a meal comfortably. This dog should be able to sleep through the night, or sleep during the day comfortably. When they cannot achieve those, then we're getting to a point where things are interfering with, if your dog doesn't want to play ball, I mean, everyone likes to play ball with their dog, and that's sad. Nobody likes that, but it's not a basic function of life. I mean, for their mental health, yes, I would agree. But when things start interfering with their ability to eat, drink, and sleep, then we're reaching a level of disease that is, concerns me. If someone says weakness is and cancer, I don't know what if Riley asked well, cancer for exercise intolerance, the cancer is just so broad. Cancer can cause issues with the heart. Cancer can cause issues with anemia, but the cancer, you'd have to be very specific where the cancer is. Obviously, cancer in the bone is going to cause so cancer, I would want to hear something like cancer of the bone or cancer in the heart or lung cancer. So you see what I'm saying? I want a little more specific reason, but I want you to be thinking heart respiratory anemia. Now, weakness can come from the anemia. Weakness can come from heart disease because heart is not pumping. But I will tell you, dogs sometimes in severe diabetes and severe liver disease will be weak. Fainting and a seizure, these are hard to separate. And I told this story to you guys a long time ago. We had a Shar-Pei, and I'll send you guys a video of a procedure, but we had a Shar-Pei. Owner calls, says my dog's passing out at home. I was working with a new doctor. She was kind of brand new vet, called her baby doctor. And she goes, I think this dog's having a seizure. He's coming in. Well, the dog gets to our lobby and it does it. It passes out in the lobby. So the receptionist is like, come get this dog. So it's a Shar-Pei, 9-10 years old. So, 40, 50-pound dog, lift it up. We start doing a physical. Right away, I'm like, this dog is super pale. So very pale mucous membranes, having a little bit of respiratory distress. Dog has a heart rate of 180 to 190, which that's like a cat heart rate. That is not a Shar-Pei heart rate. So right off the bat, I'm like, and the pulses are weak, very, very weak. And then I go to listen to the heart. I cannot hear this dog's heart. Barely. It's very, very muffled. So all of a sudden, I'm like, what do you guys think I'm looking at? The doctor was still thinking seizure. She goes, I think this is a seizure. I'm like, okay, can't hear the heart, weak pulses, pale, tachycardic, low blood pressure. Amen. This dog had pericardial effusion. We called in the specialist, who was my boss, was the criticalist, and I was texting him, and I'm like, dude, you got to come in here because I think this doctor's barking up the wrong tree. She was going to call him in anyway, but I gave him a little, and as soon as he put the probe on the heart, this dog had pericardial effusion, and we did what's called a pericardial tap. And we give sedation, we put a needle into the space between the pericardium and the heart. We start pulling off fluid, and when we start pulling off the fluid, it's straight blood. But when we started pulling the blood off the heart, all of a sudden the heart rate started going 180, 160, 150, 140, got down to 120 because the heart could expand. And then we found a tumor on the heart. So what was happening was the fainting or the seizure-like activity was actually heart-related. Now, I will tell you, dogs can have a fainting-like seizure where they fall over, and it's true seizure activity. But if it's a seizure, that dog could have a high heart rate, but the heart rate wouldn't be so high. I could probably hear the heart. I could probably feel pulses. You see what I'm saying? This dog also didn't have any nystagmus, any, pupils were bilateral and reactive. normal reflexes. So in fainting, you've got to look at the clinical signs. And the muffled heart was because the fluid was around the heart. So that just gives you an idea that, you know, and obviously the other thing, and there's a note at the bottom of the slide here about hypoglycemia. There is also, if they're completely hypoglycemic, but again, normally that severity of hypoglycemia is seen in like a baby Yorkie. You know, people adopt these tiny little Chi-Poos or Yorkie Poos or Chihuahuas, and they fit in your hand. If they don't eat for a day, like they don't feel good, their blood sugar can plummet. So if a little kitten came in passed out, my brain is probably going to go to either flea anemia or hypoglycemia. So you start to develop a database in your head, like, okay, you fit the profile of this, you fit the profile of this. So hopefully that makes sense. And I know I spent a lot of time on this slide, but what I really have, you guys need to learn to be analytical. There is, in school, there's straight up memory, and that comes with experience. So I realize that. You see enough cases, you start to put pieces of the puzzle together, but start to think about the physiology of how the heart pumps. It's logical why that dog passed out. The heart was being restricted from fluid around the pericardium or in the pericardial space, and it impaired blood flow to the organs, the brain being one of them. And that's why the dog passed out, because it was inadequate perfusion. Okay. Now, if unexplained bleeding, it's not a question that's up there when I usually take in a spay, but if you're taking in a case that's, you know, any blood in the urine, if we're seeing an injury, did it clot properly? Now, normally the owner is probably going to say, wow, his leg bled forever. Or look at this bruising on his belly. Anytime you've got bruising or excessive bleeding or oozing bleeding, is we're typically thinking about coagulation. Now, our coagulation factors, I will tell you, anytime you have a dog that has any issues with the liver, elevated liver enzymes, sometimes affects the clotting factors because a lot of them are produced within the liver. So sometimes liver disease and bruising can kind of go together. But, you know, a coagulation panel isn't something we do every day. But if we're going to go into an advanced surgery and we're operating on the liver, especially if you're going to do orthopedic surgery, the bone has a lot of blood supply. A lot of doctors, if there's any question about bleeding, are going to be very cautious before they do surgery to make sure the blood can clot. Because we don't want them bleeding out after surgery or having excessive bleeding. And the aspirin use is one of the things that I told you about, is that a lot of people, there was a kind of a craze, and it's maybe still right now in people, to take a low dose aspirin every day. And I think I want to say it's like 81 milligrams. They make a low dose aspirin now. And it's supposed to help with joint health, inflammation disorders in people. Well, what a lot of people do go and they say, well, if it's good for me, I'm going to do it for my dog. So a person's taking low dose aspirin, they give it to their dog, you know, and we're going to start NSAIDs or we're going to do surgery. We need to know that. One other thing to mention with this disease, or getting all of our information, we're trying to prevent any side effects. We're trying to prevent anything that we can troubleshoot that potentially would be a worse outcome from the patient. And again, a coagulation panel isn't on our normal list of blood work, but if the dog has a risk factor, we're sure going to add it in. Okay, so if there's any questions about that. The other thing is the consent. I've already kind of mentioned getting the forms filled out. And normally your estimate will have that. Um, it is technically, oh, Haley, yes. So Haley, the patient, when animals are on aspirin, it thins the blood. But what it actually does is it impairs the body's ability to clot. I mean, on aspirin, the patient might ooze a little more or bleed a little more than expected. So normally if they've been on aspirin, unless we're going into an emergency surgery, you're going to take your chances. A lot of times we'll have the animal stop the aspirin for 7 days and come back. Also, it's mostly a bleeding issue. The second thing is if they're taking aspirin and then the doctor wants to use Rimadyl or Deramax, they cannot get aspirin and an NSAID together. Okay, so sometimes we also want to know about aspirin therapy because we're going to start an NSAID after surgery. They would interact with each other. But mostly I was stressing the bleeding. Does that make sense? Or hopefully you heard all that. Okay, so hopefully, Haley, that made sense. And okay. Now, again, the considerations, one thing also, there's a lot of forms. I'm not going to spend a lot of time on this. You'd probably did BOP and talked about consent forms. A lot of surgical estimates build in consent with the estimate. So it's an estimate and permission. One thing that we keep separate of that, or at least at VCA, every patient has to fill out a CPR order. What are your wishes if something goes bad? And it's very, this takes a finesse and practice, but I would have oncology clients are already sad because their pet has cancer. So anytime they were going to have a CT scan or we were going to set up radiation therapy, I would go over the estimate and then I'd say, I need to know your wishes if something is to happen. And I said, anesthesia is done safely every day, but there's always those scenarios where things happen that we cannot predict. And I want to make sure that I'm following the wishes that you would like. I mean, I try to keep it now most people understand if you went into a human hospital, if you went in for a procedure, they would want to know your wishes or a family member's wishes. So it's not like this is a foreign concept to people. It happens in hospitals every day with people. But when people think about their animal, it's a different kind of experience. And people don't want to think, when they see me walk out with their dog, they want to know they're going to see their dog again. And so I try to give them every, assurance, but I have to have that legally on file because I have had clients that don't want anything done. So that usually has a phone number on that paper. I always confirm the number, like I told you, read it back, and I always make sure that they can be reached. Are you going to be in a meeting? You don't have your phone. You're not allowed to take a phone call at work. I need to know potentially also, do you have an emergency contact that if I can't reach you, I can call this person? So you want to get that filled out ahead of time, and it just removes confusion. And just so you guys know, what we do at VCA is we do something called start and call. We are going to start compressions. We're going to give emergency drugs. We are not going beyond the scope. CPR to initiate, we will know usually within about 5 or 10 minutes if we have a chance to get that dog back. But if it's anesthesia related, even people that didn't want CPR, I'm like, a lot of things we can start and call. And I told owners, realize we're not going to go crazy if you don't want us to, but there's a lot of initial drugs that we can give. We can reverse anesthetics. We could administer oxygen and fluids and atropine, and that may make a difference. So there is a little bit of counseling. I've had to give some clients, they ask a lot more questions. Some people go, yep, here you go, here's the paper. So, we have to make sure. But checking that number is always going to be a very key thing to do. Now we're going to talk about the physical exam and kind of the steps that we go through, on this little checklist. So let me break them down. The difference between a physical exam, a PE versus PA. Now, a lot of people call it the same thing. I have to admit, I will say, hey, I already did a PE on that dog. A PE is technically performed by a veterinarian. I will tell you, I would be extremely uncomfortable if any doctor I worked with took my physical exam and okayed the procedure and never listened or looked at the dog. And I've been doing this a long time. I feel pretty good with my physical examination or my assessment skills. But that doctor is the licensed doctor for that patient. If something happens in a court of law, they're not going to come looking for me. They're going to come looking for the doctor. So technically, we go in a room and do the patient assessment, the history, and I do a once over, feel the dog, listen for the pulse, or listen for the heart, feel the pulse. And then the doctor's usually going to come in. I will tell you, there's a couple times, or there's a scenario, if I have a cat, I go in a room and the cat's in a carrier and the cat is growling or very scared, or especially if they're having respiratory distress, I'm not going to drag that cat out, do an exam, put it in the carrier, and then take it out again for the doctor. So normally what I'll do is I'll look in the carrier. I can get an idea of how their eyes look. How does their coat look? How are they breathing? What is their mentation? I can look in a carrier and get all of that information. And then I'll take it in the back, and then the doctor will do the PE. So there are times where I go in a room and I just do a visual if the dog is extremely aggressive, if the cat is stressed or aggressive, exotics. And I know Nemer's probably, I'm not going to like stress a rabbit out and then get it out again for my doctor to do another exam. It's like, let's just stress the patient out one time. So there are times where I just do a visual hands-off assessment, history, talk to the doctor, then do a physical exam. So I do want you to realize, you're both going to do it, but there are times where don't double your work. You want to look and have a consistent pattern. Head to tail is basically, and think about organ system. One thing that I have added on here, and this is probably, you've already learned that I have my soapbox moments. A lot of people will just put a stethoscope on a dog and get a respiratory rate. And there is a lot more to breathing, especially if we are concerned with any kind of respiratory disease. This is what I usually do. When I walk in a room, most animals are excited and they come up to you, or they're scared and they hide behind the owner. So I walk in, I introduce myself, and I start just talking to the owner. I don't even necessarily look at the pet initially. And then sometimes the dog comes out and they're like, if I walk in a room and I go right to a dog, sometimes that makes them scared. Or if they're very excited, I might play with them a second, but then I talk to the owner and I let the dog calm down. Because if you do everything right off the bat, you're going to get sometimes a heart rate that's too high. The next thing I do is I literally stand back and I watch them breathe. I can literally take a respiratory rate from across the room. I do not have to have a stethoscope on a dog to get a respiratory rate. I just watch them and I go, I count, I write it down. I write kind of my assessment, and then I actually touch them and listen. Because how hard is it for that dog to breathe? Work of breathing. Remember when I've told you guys, in and out with minimal effort. Now, obviously, you want to look at their coat color. We want to know their hydration level. Okay. But the cardiovascular, the nervous system, and the pulmonary systems are the ones that are the most affected by anesthesia. So these are the body systems that I'm going to have to make sure are normal. We're almost done here. Hold on. Big thing, Make sure when you take them, now this is like we're doing the assessment, we're taking them in the back. Everything, color, ID tags, their cage tag is ready to go. Body weight is key. If they are under 5 kilograms, which is roughly 10 pounds, most clinics have what's called a baby or a pediatric scale. And exotics technically use a gram scale. That little like thing you weigh, like if you're into nutrition, you can kind of weigh your portions. We typically weigh them before the anesthesia procedure. And another thing that you should be doing, our software at BCA, you put in the weights and it'll automatically compare and create a chart. But if you weigh a dog that was in 2 weeks ago and it's 5 pounds lighter, is it losing weight? Is that an error with your scale? If you're not ever sure of the weight of your patient or the scale was not accurate, go ahead and get a bag of dog food that we know weighs 40 pounds and put it on the scale. If it says 40 pounds, your scale is probably accurate. I had a lady argue in ER with me, and it was like a husky mix that I was taking in, and she's like, no, my dog weighs 20 more pounds than that. You did that wrong. And I was like, put the dog back on. I got the same weight. That can't be right. My dog does not weigh that much. And she was getting pissed. So I walked in the back. I got a bag of dog food and I put it on the scale. I said, ma'am, this is a 40-pound bag of food. That scale says 40 pounds. And when we started feeling the dog was bones. And then the lady felt awful because she goes, oh my gosh, the fuzzy like huskies and shepherds, they look so furry, you don't necessarily see that they've lost weight. And then all of a sudden you feel them and you could feel the bones. Dog had cancer, unfortunately, but it was like, yeah, I'm sorry, your dog has lost about 20 pounds. And she just felt floored. And I was not trying to embarrass her. I was just simply saying, ma'am, the scale is accurate. So you will have people that question that, but you always want to make sure you get the current weight. And if you are in a referral practice, a lot of times we would get sent a weight that was maybe when they saw that dog a year ago. I never go by what the scale says or what the paperwork says from a year ago. You're always going to do it sooner. Now, you guys have done the body scale. We usually, if you're going on a 1 through 5, your 3 is ideal. If you're a 1 through 9, 4 to 5 is going to be more ideal. 1 is going to be the absolute cachexia where they're breaking down their body, and 9 out of 9 or a 5 out of 5 is they're going to be extremely obese. And I'm going to tell you that there is some important notes under here. The thinner they are, they're more sensitive to barbiturates. They're prone to hypothermia. If they're overweight, they might have issues with ventilation during anesthesia. Their body puts more pressure. Also, whenever we dose an animal, and I will get into this when we talk about drugs, you are going to dose or do the dosage on their ideal weight. If you have a Labrador that weighs 100 pounds, but it looks like it probably should weigh 80 pounds, I dosage that animal on 80 pounds. That dog has the brain and the lungs and the heart of an 80-pound dog trapped in a 100-pound body. Okay? So, and if for some reason I don't give enough, I can always give more. But you can overdose an animal if you dose them on their obese weight. So that's just a typical anesthesia thing I want you to burn in your brain. You're going to have to kind of do some estimation. Your doctor will help you. But I normally do that. I will normally drop, maybe 20 pounds off of it or whatever and calculate. Since it's 11, let me stop there. So I know we have more to get into. Does anybody have any questions based on what we've said so far? Did I answer the aspirin question? Trying to give you as many history-taking tips, analyzing tips, but I hammer this home for you guys at this level in the program. It's analyzing information. Animals can't talk to you, so we literally have to interpret signs and interpret data to come up with what we think. And so the more you start to critically think, the better off you're going to be. Okay, well, nobody's typing anything or saying anything. So, oh, if you combine NSAIDs and aspirin, you can get GI ulcerations. So you're going to get GI side effects, potentially vomiting, diarrhea, potentially melena, where you get the black stool. So they can, when it's kind of like NSAIDs and Pred. If you use Pred, which is a steroid, you cannot give it with a non-steroidal because the GI symptoms is what we're worried about, Joycelyn. That answers your question. Yep. Okay. Well, if there's no other questions, I'll record this. I'll email it out here in just a bit, probably within the hour. Again, I'm going to keep sending these individually. I'm not sending like a mass email with a bunch of links, but I'm trying to label them with the date or Friday or which PowerPoint so that you know which one is which. So those of you that got bopped out or had issues with Wi-Fi, hopefully you can potentially go back and play this and, you know, feel free to zoom through or whatnot. Okay. Yeah, make sure, yeah, you have a good weekend. Make sure you put here, I mean, if you've already put here, you're fine. I'm going to bop out of this. Got to check on my dog a second, but you guys have a good weekend. Bye, Joycelyn. You guys have a good one. Okay.